Good afternoon, everybody. This is our now weekly COVID-19 webinar series for healthcare providers. Today is June 4th. This is Dana Harganani, Chief Medical Officer for the Oregon Health Authority. And I am joined by Dr. Tom Jean, our Deputy State Epidemiologist and Public Health Officer, as well as Dr. Ariel Smits, our Health Evidence Review Commission Medical Director. All of us working on COVID-19 and glad to join you. Hopefully, if you're on this webinar today, you've noted our change in momentum with these webinars and scheduling. We are now doing weekly webinars every other week, or the first and third weeks, as in today. We're hosting these webinars here at the Oregon Health Authority. And on the second and fourth, we're joining OHSU's Project ECHO. So again, we're focused on getting you information once a week now. We'll continue to reassess as we move into this COVID-19 response. A couple things we want to note just before we jump into our agenda. We have changed our approach in our room, and we are trying to get to a point that we can monitor our chat box during our sessions. I'm currently locked out, so I'm trying to get back into the chat session, the chat room, but we hope to be able to see and screen your questions real time. If there are questions we can answer right away, I'll open them up to our group, or I think we can answer. If there's anything that we know we need to take back to do more research or make sure we have accurate information, we'll be bringing them back to you in the future. So we will definitely try to work through that as we get going through this new format for us. Moving ahead in our agenda today, we're going to start with some epi updates. We're going to try to switch up some of the data we're showing you. We'd be very glad to hear moving forward in your response to us, what kind of data you'd be interested in. We want to make sure this is relevant and most useful to you. So we're taking a stab at it today, but we'll look for your input. We're going to briefly touch on some immunization updates. We'll move then into talking about reopening and looking ahead at phase 2 and beyond. We're going to share some updates that we've been monitoring in the literature, and then close with some COVID-19 questions that we've received from you to this point. So jumping into our epidemiology update, here's some numbers we'll continue to share with you. We have a total now of nearly 4,400 total cases. The majority of those are based on positive tests, and a small number are based on presumptive case diagnosis, presumptive case definitions. We've had a slow and unfortunate uptick in our deaths from COVID-19 at 159 as of yesterday. And here we're at over 136,000 tests for COVID-19 completed. And as you know, we've always stated that our testing and our case counts do not represent the full impact of COVID in our community. Based on our last modeling update, it predicted that we've had over 20,000 cumulative infections in Oregon. That was last updated on May 29th, and you can see that modeling update if you're curious here on this web link.
I would add that Oregon is fourth lowest in the nation among states for COVID-19 cases, and sixth lowest for deaths. So certainly unfortunate every time we add deaths to our count, but we are far below the national average.
Great, a couple more pieces of data to share with you. Already mentioned the tests done. Last week, between May 25th and 31st, there was over 18,000 tests done, really representing our increasing capacity that we've seen in the state, which is fantastic. Also last week, our percent positive results were about 1.9%. This was a slight uptick from the week prior, but still well below the national average. As you know, on our weekly report, we also provide information about recovered cases. To date, based on the monitoring we do with our cases, we've noted 1,558 recovered cases. And I find the other two data points here useful information. The median time to recovery among symptomatic cases is currently at about 21 days or 3 weeks. and the median time to recovery for symptomatic cases who were hospitalized is 25 days. More information about recovery data on our weekly report. I also wanted to just update you about some new information we are now putting out in our weekly report. So you would be able to see this as of our last report, which was posted yesterday. This is a new table that looks at active workplace outbreaks with 5 or more confirmed COVID-19 cases. And for this report, workplace outbreak is defined as 2 or more COVID-19 cases that work in the same location, have an epidemiologic link, and have symptom onset or positive tests result within 14 days of each other. We have made some choices in how we're presenting this data to protect privacy. For example, OHA is only reporting workplace outbreaks with 5 or more cases, and only for workplaces where there are at least 30 employees. I think when you look at the list of active workplace outbreaks, you'll note that correctional facilities and food packing and other agricultural work sites are heavily represented on this list. And as you might expect, it's really illustrative of the challenges in controlling COVID-19 in settings where people must work or live in close proximity. And in addition, people of color are overrepresented in some of these workplaces or correctional settings. And this may contribute to the higher rates of COVID-19 we observe in these groups. If you look at this workplace report, for example, you'll see the top is the Oregon State Penitentiary, currently with a total case count of 167 in the most recent onset of May 27th. So these are just some examples. We're going to continue to update this, including a list of outbreaks that have already been resolved. They'll be moving to a separate table of resolved outbreaks that we're planning to publish on June 10th. So we invite you to take a look at this. We are actively working to communicate this information moving forward. Passing this off to Dr. Jean.
Thanks. So I wanted to go through a few of our public health indicators. We've now got a nice section of our website that has these indicators in kind of an interactive graphical format. And again, that's at healthoregon.org/coronavirus. And there are some blue buttons towards the top of the page that'll take you to reopening information, the public health data dashboard, as well as our weekly report and our daily report a little farther down the page. So these are from the data dashboard, and just to show some of the highlights, these are indicators that we're watching as we reopen Oregon. And the first one here is hospitalizations for COVID-19. So number of COVID-19 cases admitted to a hospital each day. The orange line is a moving 7-day average, which takes out some of the variability from day to day. And you can see a clear trend here from late March, which is what we've been reporting for weeks, but it's continuing to look good. Another of our indicators that we've been highlighting is the percentage of emergency department visits for COVID-like illness. And this is really a sensitive kind of early warning because we have this data in almost real time. So it's encouraging that we're still below our baseline, our average for flu-like illness, which of course is a very similar definition to COVID-like illness outside flu season. So that's about 1.5%, and probably in part due to all the social restrictions, physical distancing, et cetera. We are actually below our normal flu-like illness baseline for emergency department visits. But again, we'll be keeping a very close eye on this as we reopen to see any uptick in visits. And another example of an indicator is focused on more of the public health response, and this is the time between diagnosis of a COVID-19 case and follow-up from a public or tribal health authority in terms of case investigation. We want to see that. We want those to happen within 24 hours. And there are reasons that sometimes it's very difficult or impossible to contact somebody in rare cases, and that it can take more than 24 hours. But generally, we've been doing better. We've had fewer and fewer with greater than 24-hour time to follow up. And that's important so we can do a case investigation and do contact tracing and get people the information and resources they need, and so they can isolate and quarantine and prevent spread of the disease.
Just another quick look at the trend data of currently hospitalized patients across our Oregon hospitals. This is reported through our HOSCAP web page by hospitals, and just wanted to give you a quick glance as we're monitoring this closely. We're basically at a plateau right now, kind of up and down within the 40 to 60 number of positive patients currently hospitalized. In the orange line, again, you can see of those who are in an ICU bed, and of those, the number that are currently requiring mechanical ventilation. So again, just monitoring this closely as we move through reopening phases, and seeing that we're again at this plateau for the last couple of weeks. Before we go on to a brief discussion of immunizations, I was able to unfreeze the screen, and I'm going to pose a question to Dr. Jean. The question is OHA combining antibody tests and viral or PCR tests in data that shows our number of tests done and our testing capacity?
Oh, good question. So this is specifically asking about test capacity and the number of tests we have, right? So those are focused on PCR, or molecular or viral testing, which is really the only testing for diagnosis of COVID. The serology or antibody tests will be very important, are important for getting a sense of the prevalence, but they're really not very useful for diagnosis. So when we're talking about test capacity and measuring that, that's all PCR. At some point, we may consider including antigen tests in that, but there aren't a lot of antigen tests currently being done. It's mostly PCR, which is the gold standard.
Great, thank you. Just a brief update on immunizations. I know this is a really important topic for our population and for our healthcare providers. We've spoken to you before, sharing some CDC updates as well as some survey results from the Oregon Health Authority. We know that immunization rates continue to be low compared to this time in 2019. Our immunization program has mentioned that we're hoping to see, we think we're seeing some improvement in immunization rates among the youngest ages. But we're going to be updating our data and updating surveys in the next couple of weeks. So we will definitely be bringing that information back to you. We encourage you to go ahead and look at what we do have posted on our immunization website. I've shared the link here. I'm going to show you a snapshot of the data on the next slide in just a moment. Did want to let you know that right now we are planning to carry on as normal with immunization requirements for childcare in school. And so we really need your help making sure to get children, adolescents, and of course adults as well vaccinated. And our immunization team is also really focusing in additional emphasis around influenza vaccination this fall, with more information coming, but that is really an area they're gearing up for and important for you to have on your radar. In your clinical setting, how are you going to maximize ensuring access to influenza vaccine, as well as getting other vaccines updated? We know that you're all probably putting in place best practices, wanting to learn more about best practices for vaccine catch-up on particularly on a large scale. Our immunization program is planning to do a webinar in the near future. We'll keep you updated on that, as well as other data forthcoming as we're doing further monitoring. For now, I will just show you what's up on our website. This is what we have been monitoring thus far, comparing immunization that have been administered between the same time period in 2019 to 2020. This looks at the EPI week 12 to 18 that we monitor as a state. So basically the time since the COVID-19 pandemic emergency was called. So you can see here for the youngest age vaccines, looking at DTaP and rotavirus, we have about a 14 to 15% reduction in administration of those vaccines during this time period compared to 2019. When you look a little bit older age group, so around a year, the first MMR given, we're down about 25% compared to last year's administrations at this time last year. if you look a little bit later at second dose of MMR or older Tdap and HPV vaccinations, you can see this is where there is the most significant decrease in administration of these vaccines compared to this time last year. All of these are critically important. I think it's great. We've been emphasizing the importance particularly of those really young kids, but all of this is extraordinarily important. So stay tuned for updates to this data that will be forthcoming soon, as well as more information our immunization team is putting together. This we can't underestimate how important this work is. All right, I'm going to pass it back to Dr. Jean for some information about reopening Oregon.
Yeah, I just wanted to briefly touch on reopening in Oregon. As you know, there are different phases, and we're having individual counties in Oregon apply for each phase. So yesterday, Governor Brown had a press release and a press conference all about phase 2, and so you can find a lot of information about that. But basically, she outlined some of the new guidance and the new requirements that will be part of phase 2. So phase 2, actually, if you want to go 2 slides forward to look to the map. So most counties are currently in phase 1, and in phase 1, things like the gatherings have been expanded a little bit to allow up to 25 people in social gatherings, for example. Personal services like barbers and salons are allowed. And so Multnomah County is the one county that's still not in phase 1 yet. And the plan for Multnomah County, I understand, is to apply this Friday and potentially enter phase 1 on June 12th. All other counties are in phase 1. Our approach, the governor's approach, requires a county to be in phase 1 for 14 days before they can enter phase 2. So let's go back a slide and just showing the different the guidance that is part of each phase. And so what was kind of announced yesterday is some of the new guidance for phase 2, including smaller venues, medium venues, sports and camps, indoor and outdoor activities, and other outdoor recreation. And there's also some changes for some of the existing guidance. So for example, in phase 1, restaurants are required to close at 10 p.m. In phase 2, that changes to midnight. And there's also changes on return to work and travel restrictions. So don't have time to go into all the details here, but again, on our website, there is that link to reopening criteria and some of the specific guidance. If you have questions, for example, about any of these sectors, I encourage you to go and look at that.
So I have a question that we received about reopening, and I think you briefly talked about it, but I'll just state it. Talks about media reports within the past 2 days indicate the governor will allow capacity of up to 250 people, for example, inside faith-based communities like churches. Is this true? Can you speak to that, Dr.
Yeah, so part of phase 2 is a limited reopening of certain sectors, and there's a cap of 250 for some of the larger spaces, and I think that would include theaters, movie theaters, and churches, other faith-based organizations. So assuming they have the space to maintain the physical distancing, 250 would be the maximum cap according to my understanding of that.
Great, and for all of those who want more details about that and exactly how the state's approaching that, this guidance is now up on the website, so I would encourage you to take a look at that. We're all still learning this too here at our agency, and so we'll keep you posted on new information as we move forward. Another question I'll call out here before we move on. There was a question about recovery. We shared some information about the number of individuals who have had COVID-19 and recovered. Can we talk a little bit, Tom or Dr. Jean, can you speak to how we define recovery?
Yes, off the top of my head, I might have to pull up our investigative guidelines. We have a clear definition of recovery, and what I think the numbers are being reported based on follow-up calls that our epidemiologists are doing to people who had cases. And they ask them a bunch of questions about their symptoms, and that's how they assess recovery. So I'm not sure I have the specific definition of recovery handy.
Right. I too just looked at it this morning when I was pulling the recovery data. I do think it aligns with the 10 days and fever resolved, our kind of remove our requirements for removing from isolation, for example, and we can get that too. It is listed on our weekly report.
So from our investigative guidelines, there's two ways to assess recovery, and they may be updating this, but currently there's the symptom-based recovery. So somebody who had symptoms is considered recovered when it's been 10 days from onset and they've been afebrile and have been improving other symptoms for 72 hours. So that would be at that point, they would be then listed as recovered. There's also a test-based strategy. So if they've been afebrile and other symptoms have improved and they've had 2 negative tests at least 24 hours apart, that would be considered recovery too.
So I will pick up some more questions in a little bit. I am going to move us on. And Dr. Smith, can you speak to some of the literature updates we've been monitoring?
Sure. This is just things that have kind of come across our plate that we've thought might be interesting or informative for you all. The first one is from the Oxford Center for Evidence-Based Medicine. They have scraped data from wherever they could find it for basically every country in the world. There's a really interesting table on their website. But I pulled out just some what I thought were interesting examples of countries with similar health systems to the US to kind of show you a variation in case fatality. Case fatality, if you remember from your epidemiology classes, is the number of deaths divided by the number of cases. It's very sensitive to the number of cases. So if you're not testing very much, your case fatality rate will be much higher. It can also be really sensitive to other things like Italy, as you notice, has a 14.4% case fatality rate. They have the second oldest population in the world, and they have a very high percentage of smokers compared to many other countries. So that might be one of the underlying reasons where their case fatality rates are a lot higher. Or again, not finding a lot of less symptomatic cases. So interestingly enough, France has the highest case fatality rate. Iceland has almost no fatalities. The US is sort of in the middle here. Right now, according to this analysis, our case fatality rate is about 5.5%.
And I would just wanted to add that Sweden, which has been in the news because they have not locked down to the extent of other countries, they're of course on the list as well, and I think they were around 11%. Yeah. So certainly quite a bit above the US and Germany.
And Canada, which is right around us. Mm-hmm. So one of the things that's been in the news a lot lately, and I've been seeing a lot of literature on, is convalescent plasma treatment. This is where a person who has documented COVID-19 recovers and then donates plasma, and the antibodies to COVID-19 are removed and used to treat another patient. Cochrane did a rapid review of this a couple of weeks ago. They found 8 studies, all case series. And they basically couldn't come up with any conclusions about whether it affected mortality, clinical symptoms, length of ICU, or hospital stay. They couldn't determine whether there was any serious adverse events. So basically, they couldn't really conclude much of anything, but did notice that there were 22 ongoing RCTs. And yesterday, if you want to move on to the next slide, in JAMA, one of these studies was published. This is a study out of Wuhan, China. It involved 103 patients. It was a randomized trial. 52 patients received the convalescent plasma, 51 patients had standard treatment alone. Their standard treatment would be slightly different than what we do in the US. It included Chinese herbal medicines and things. They used a rather potent titer of the antibody, which is 1 to 640, which is just means that there was a high amount of the specific IgG antibody that they were using. Of specific note for this study, it was terminated early, and it was due to a lack of eligible patients in Wuhan before the end of their study period. Next slide. So in this study, they found no significant change in the improvement in symptoms in 28 days, and they stratified this based on disease severity and didn't see any significant difference, although there was a slight non-significant trend toward improvement. They didn't see any difference in mortality, and they didn't see any difference in time to discharge. Of note, 2 of the patients in the plasma therapy group had significant adverse events. One of them had anaphylaxis, and the other had something which they couldn't quite determine, which may have also been a less serious anaphylactic reaction. Both responded to IV steroid treatments. So their conclusions were that the convalescent plasma therapy doesn't appear to be any more effective than standard treatment. Of note, this could be an underpowered study, but taken together with the Cochrane rapid review, it's making me a little bit less optimistic that convalescent plasma will be an effective therapy in our arsenal. Obviously, this is subject to change as the literature evolves rapidly. And then this one was particularly interesting to me in my clinical practice. Many clinical practices in Oregon have switched to doing a lot of telemedicine, so either telephone or video visits rather than in-person visits. And I know that a lot of us have questions about whether this is affecting any patient outcomes. So Cochrane also did rapid reviews specifically looking at this. Of note, the reviews that were included in the rapid reviews are from an era prior to COVID. So these are when patients could come into clinic and get labs done or have visits in person. And these were added, telemedicine was given as sort of an option. But they found no difference in asthma outcomes of any kind, so hospitalizations, ER visits, etc., when you did telemedicine versus in-person medicine. And they also found moderate to high quality evidence that in diabetes care, that you actually might improve care a bit. Again, these are patients who probably could come in and get their labs drawn, etc., and this might be reflecting that perhaps they had greater access to care, greater ease to care. A little bit concerning is the fact that they couldn't find any consistent data that this was an improvement or neutral for heart failure. It may be worse for heart failure patients. So just to keep that in mind as you reopen your clinics to see people in person. Based on this data, you might want to prioritize more of your heart failure patients, et cetera, but to be reassured that hopefully we haven't done any harm for our asthma and our diabetes patients. And then one thing to keep in mind, and I was thinking about this when the previous question came up about how do you determine if somebody has recovered. Again, in yesterday's, actually this may have been last week's JAMA, there was an article about persistent COVID-19 positivity. So this is a case series of 60 patients. They all were hospitalized and were PCR positive for COVID-19. 10 out of the 60 were positive for COVID-19 up to 24 days after hospital discharge. So this is after clinically they were improved, but they could still have PCR detectable virus. And it was both detectable from oropharyngeal swabs as well as in the GI tract. We don't know what this means. It means they may just have pieces of virus. They may not, we doubt they're infectious. But if you are thinking about testing somebody to see if they're recovered by doing another PCR test, it may come back positive based on this data. And just to be aware of that. And that if someone is persistently positive, they're probably not infectious, but to be aware of that.
Yeah, beyond 10 days, we haven't seen studies that show any culturable infectious virus beyond 10 days. So that's kind of the reasoning behind that.
Yeah, and this was in a group that they also looked and made sure that they had maintained sort of a quarantine at home and they didn't think that they were reinfected.
That's 10 days after symptom onset. But PCR can detect parts of the virus that may not be viable. And so we've seen, up to 60 days or more positivity from PCR.
Before we go on to clinical questions, Dr. Jean, I think you had some additional updates and I have some questions for us to respond to.
Yeah, I just wanted to highlight a couple things regarding testing. I talked to one of our staff members in our state lab, which is part of OHA. They're out in Hillsborough, and they've been fielding concerns from some providers about false positives from viral testing. So either a PCR or molecular test, including the Abbott ID Now, which has been in the news about its reliability, and I think also potentially about antigen testing. So the concerns with ID Now and some of the more rapid molecular tests is really a question of sensitivity, and so that means we're worried about false negatives. In other words, the test is coming back negative on somebody who's actually got the virus. That's the sensitivity. I have not seen any data to suggest that any PCR or molecular test is turning out a lot of false positives. They tend to be very specific. If you get a positive, it's almost definitely a true positive. So if you have concerns that your lab or the lab that you're using might be returning false positives, please discuss that with your lab. That's really more of a quality control or quality assurance issue. The tests themselves are very good in terms of specificity, so would not worry about false positives. Now, that's completely different from antibody testing. When you have an antibody test that's, say, 96% specific, as I've explained in previous sessions, and you have a low population prevalence of disease, even though that 96% specificity sounds pretty good, you can end up having a pretty poor positive predictive value. In other words, you could have half of all positives might be false positives. And that's just how the math works out with the prevalence and the specificity. But again, for the molecular testing, the viral testing that we recommend for diagnosis, false positives are really not something that I would be worried about. The other thing I wanted to highlight was we just yesterday published an update to our guidance for clinicians on COVID-19 testing. It's available on our website, and we've tried to highlight all the significant changes in blue text for your convenience. The main changes are we added some information about our recommendation for only using tests that have FDA EUA or FDA approval, and we added some information about serology testing, which had previously gone out in a health alert network. We also continue to recommend or not recommend routine screening of asymptomatic people for COVID-19. And that's because it's just not very useful because of that sensitivity issue. Sensitivity of these tests in people who don't have symptoms is quite low, and therefore a negative result doesn't really increase your confidence very much that a person's not infected. There are some exceptions, and we've added a new section. So people who are close contacts of a person with lab-confirmed COVID-19, for example, they would be somebody without symptoms that we would recommend testing of. People exposed in a congregate setting with an outbreak, for example, like in a long-term care facility. We've also added migrant seasonal farm workers upon arrival in Oregon, and then people of color, people with disabilities, or people whose first language is not English, just due to their higher risk and their higher pretest probability and concerns about access to testing. So with those exceptions, we're not recommending routine screening of or testing for asymptomatic people.
Great. I'm going to bring up a couple questions that we've received here to see if our team here can answer them. There's a question about what guidelines, if any, are there for medical providers returning to work after travel to other states or out of the country?
I would say to talk to your employer. I think this is probably health system dependent. They may have certain areas where they feel like you should isolate, certain other areas where they feel like you should monitor symptoms. So I think you need to go to your occupational medicine or your employer.
I would totally agree, and I'd also say that at OHA we don't have an official quarantine recommendation for returning travelers at this point. We'll certainly keep an eye on the epidemiology around the world. That said, if you travel for any reason, even if you're not a healthcare worker, and you've been in contact with a lot of people, or you were in contact with somebody that may have had COVID-19, a self-quarantine at home for 14 days is not a bad idea, or at least restricting your activities and avoiding gatherings, avoiding non-essential visits to stores and things like that would be a good idea. But there's no official recommendation on a quarantine for travel.
An earlier question asked us about screening protocols and recommendations for colleges opening up, and we just want to share that the guidance regarding to colleges and school reopening is coming directly and led by our education colleagues, either the Department of Education or our higher ed colleagues. We certainly have been engaged in advising, but we expect in the not too far future, we're going to be seeing more of those guidance coming online publicly and can certainly bring those forward to you once those are available. Another question, I'm really glad we received this question, and in fact, I had intended to open up our webinar to discuss this, but the question was whether we wanted to say anything about protests occurring right now. And I just wanted to share some of the words from our director, Alan, who earlier, a couple days ago, shared that the protest of the killing of George Floyd, while not directly related to coronavirus, certainly exposed the fundamental injustice of our flawed systems, and that includes our healthcare systems. And we know as an agency that we have more work to do to think about and address the inequities in healthcare and outcomes, and to really acknowledge those that are having feelings of fear and anger as demonstrated through these protests. We as an agency want people to know, of course, as people are exercising their right to gather and protest during this pandemic and in the wake of the killing of George Floyd, you know, we certainly encourage people to practice physical distancing where possible, wear face coverings, avoid shaking hands, things like that, using hand sanitizer, washing your hands when you can. Again, just want to emphasize our support of people exercising their right to gather and protest. The commenter made a statement about that Black Lives Matter has put out a recommended COVID-19 kit for protests. I'm not aware of that, but just wanted to share that that was a comment received. I'm looking to my colleagues if you have any other additional things to add.
The only thing I would add is using signs instead of shouting or speaking can also be a protective thing while showing your support and not exposing people to increased risk.
And we have heard anecdotally that in Portland, at least, the vast majority of protesters have been wearing masks, or face coverings, which is great to hear.
So again, support the protests and the exercising of the right to gather and protest during this difficult time. I did get a question about whether these slides are available on our website. Yes, our slides that we do by OHA are up on our website. I'm not 100% sure if the ECHO slides are on our website. They certainly are on the OHSU website. I will look into that and try to get that back to you.
And we unfortunately don't post the slides right before the session. We often have last minute additions or data to add, but I think, is it right that we try to get them up the same day after the session?
Correct.
Yeah, so this afternoon, these slides should be available to you on our website.
So we're going to move into some of the clinical questions that we've received previously, and we'll work through answering those.
So the first question we got was a comment about someone noting a significant increase in depression in their patients and wondering if this was due to OHA and CDC's guidances being too restrictive. Interestingly, there was in the JAMA issue that came out yesterday a really interesting study. This is not something that is imagined. You are definitely correct. You're seeing an increase in mental health issues. So this was a study using a representative sample of US adults. They did the initial survey in April of 2018 and they repeated it in April of 2020, and pretty dramatic increase in psychological distress. So 4% going up to like 13.5%, so almost quadrupling. So due to many things, this could be job losses, this could be illness in the family, insecurity about the future, kids home from school. I mean, there's so many reasons, but this is a very, very real phenomenon going on. We do know that many people, because of health issues, really do need to stay still at home. If you are worried about depression, particularly in your medically fragile patients, encourage them to do the things that we know help depression. So making and keeping contact with loved ones through phone calls or video chats, going outdoors and exercising, continuing hobbies and things that keep you active. But also for you all in your practices, please be aware that this is a real thing. There is a real increase in anxiety and depression out there. So working with your behavioral health colleagues to make sure that you have counseling resources. You may need to increase patient access to medications for treatment of depression or anxiety or other types of therapy. And then oh, this is one. This wasn't a question from you all. It was more just a general FYI. OHP, actually, this may have come as a question about antigen testing. So antigen, I'm sorry, this is supposed to be antibody testing. I put a typo in here. I apologize. So.
Sorry.
And that's I put the same type.
Well, I can answer this if it's helpful. We talked. There was a question that came in earlier that I'd answered similar, but this one is about reporting. The other one was about test capacity. So to clear this up, we are reporting only PCR tests currently in our case counts. We will be including antigen tests. There's only one EUA granted antigen test right now. It's the Quidel Sofia 2. We have concerns about the sensitivity of antigen tests. They don't seem to be nearly as sensitive as PCR. However, they're specific, which means if you do get a positive, if you do decide to use them, even though I wouldn't recommend it, that positive is likely to be a true positive. So we don't have concerns about that. So we are going to add them to our case definition. Those should be included in our case counts. I don't think those are being done in large volumes right now. So PCR, molecular, and antigen will be included in our case counts because those can be used to diagnose COVID-19. Antibody tests, the serology tests, cannot be used to diagnose. So we do track all those results, positive and negative, and we use them for our epidemiologic purposes and prevalence, but we do not use those for our case definition. We do not include antibody tests in our reporting of cases.
Okay, now for clarifying, this slide is actually supposed to be about antibody testing. So back to you, Dr. Smith.
So just again, bringing you all back to your basic immunology that you took in medical school. Antigen is when you're looking for the actual pieces of the virus. Antibody is the things made by the immune system to counteract the virus. So looking at antibody testing, we have adopted some coverage criteria here at OHP. For these tests, they have two different CPT codes right now. We are only accepting tests that have FDA EUA or approval, although there's none that currently have full approval as of what we know. And the only group that we're currently covering the antibody tests for are those people up to age 21 who are in the hospital who are suspected of having multisystem inflammatory syndrome in children, which is MISC-C. There's a definition for that if you're curious at the CDC website. However, this coverage is subject to change at any time as the evidence develops.
Great. A couple more questions. I just wanted to bring up that and acknowledge that I've gotten. One is more of a statement, but I thought maybe Dr. Jean, you could speak to this. This is reflecting, it's related to antibody testing, and it's just commenting on the likelihood that a positive test may be more likely to be a false positive than a true positive. Can you just talk about that with regards to antibody testing, what we know about the assays out there, and what in a low prevalence environment, what the results of those tests, what limitations they have, perhaps?
Yeah, you might. I think I can't remember. I think it was 2 weeks ago. I don't know if those slides are still up on our website, but I had some nice tables showing how the math works out. And bottom line is there are some very good antibody tests out there, including the Roche test, the Abbott test, and probably some others. But these are, I think, they're mostly ELISA tests that would be done in a lab. They're not rapid antibody tests. The rapid antibody tests tend to have lower performance. But the better antibody tests have a specificity over 99%. And so you have much lower concerns about false positives with those antibody tests. But there are still, there still could be quite a few false positives just because these tests are not quite as sensitive or specific as PCR, or as specific as PCR. So when you have very low prevalence, like less than 1% of the population that actually has the antibodies, just the likelihood that an individual positive result is a true positive goes down. So we would recommend, if you're going to do antibody testing, you need to, first of all, you need to understand and convey to your patients an understanding of the limitations of the test. We don't know yet what the actual immunity of an antibody will be. And then also be sure to explain the problems with, or the potential for a false positive. And we would recommend that you use one of the better tests if available, like those larger tests. And on our testing guidance, we have a link to the FDA EUA page, which has all the tests, over 80 tests now, including both PCR and antibody. And they have a separate page listing some of the performance characteristics of the antibody tests. Johns Hopkins also has a website that talks about some of this. They're not up to date with every single test yet, but they have some good information there.
Great. I think we've been able to address most, if not all, of the questions that came through the chat box. We're glad to be in a room that we can do that, and we'll keep that part of our webinars moving forward. We've concluded the information we plan to bring for you today. Again, just to remember, we're moving to weekly sessions, so hopefully we didn't miss anybody waiting for us on Tuesday. If you haven't already, we encourage you to sign up for the Project Echo sessions. You can see the link at the very bottom of the sign. I believe you can attend even without going through registration, but if you do get through that registration process, you can get a whole bunch of benefits and resources that wouldn't be available to you otherwise, including CME. So I encourage you to join us next week for the Project Echo Part 2 sessions that will go through the summer, and register if you can. And we will join you then, and again twice a month through our OHA work. We would still gladly take your questions through our email that we've shared before. I'm sorry I don't have it up here right now. And any recommendations for additional topics or questions that you want us to answer in future webinars, please bring those forward, or we'll look for your chat box questions next time. Again, thank you for everything you do. Be safe, and we will join you in a week. Take care.